and welcome Allison Kuntz, who will introduce our guest.
Hello, everyone. Thank you so much for joining us today. I do have the pleasure of introducing our speaker. So our speaker today is Dr. Kye Evans, and he has received his undergraduate degree from the University of Arizona and his medical degree from the University of Health Sciences in Kansas City. He completed his emergency medical training in Maricopa Medical Center in Phoenix, and he is board certified by the American Board of Emergency Medicine and has practiced for the past 18 years. So we're very excited to welcome Dr. Evans. And with that, I'm going to turn it over to you, Doctor.
Hi, good afternoon, everybody. Thanks for joining us. So we are both a wound and vein center here at LMH, located over at 6th and Main. And we're going to talk about kind of the care that we provide and take any questions that you might have, either as we go along or at the end of each session, like Kathleen said. So we'll jump right into it here. Well, maybe. Let's try this again.
There we go.
So the biggest question we always get, is what kind of things do we treat? People think of wounds, and there's a lot of different kinds of wounds. I'd say the bread and butter of our practice tends to be diabetic foot wounds and non-healing wounds. And what we mean by a non-healing wound is really anything that takes more than 3 or 4 weeks for a minor wound that just won't heal, or any kind of surgical wound that is opened up and is continuing to just persist beyond a normal healing process. And usually those are sent to us by other providers, either primary care providers, surgeons who have performed the operation and just aren't getting the result they want, or patients who have been here before and decide that they want to come back and try to speed up the rate at which it heals. We take care of, a lot of infected wounds, gangrenous wounds. The big one that everybody always is interested in is the bone infections. That tend to come with a lot of diabetic foot wounds and pressure ulcers, and that's called osteomyelitis. And we have very specific protocols that we follow to treat the bone infections. We treat both venous and arterial ulcers in conjunction with the vascular surgeons, and those typically are more difficult to heal because there's just not a good blood supply, and we'll get a little bit more into that later on. We take care of burns and radiation injuries, usually after people have had radiation treatment for cancer. Oftentimes that tissue will not heal well and requires really specific protocols to try to get it to heal. Pressure ulcers in a lot of our paraplegic and immobile patients come to us as well. And then usually in March and April, we start seeing a slew of black or brown recluse spider bites that usually come through in the spring and summer, and we take care of those as well. On the vein side, we treat obviously varicose veins and chronic deep venous insufficiency. We also take care of patients who have had blood clots, both in their deep veins as well as in the superficial varicose veins. They can be more tender and hard areas, and that's called a superficial thrombosis. We do cosmetic treatment for spider veins, both on the extremities and as well as on the face. A lot of people end up getting them on their cheeks and nose, and we treat those in the office here. And then the big one here is lymphedema and lipedema. And we always get a lot of questions about these because they sometimes get lumped into the same category, but they're very different. And I'll talk about those as we get into the venous side. On the right-hand side of your screen, you can see that there's a couple of different graphs there. The first one is just an example of different kinds of wound breakdown, going anywhere from just the skin being damaged to all the way down to a bony infection and a gangrenous foot. And that can happen anywhere on the body. And then on the lower one, there's some examples of what, normal veins, spider veins, swelling changes that happen with venous disease and ulcerations that can occur in venous disease as well. And move on to the next slide here. So how do we treat these wounds? The big thing is kind of when that patient comes in the first time, we want to know what's been done already. Oftentimes, people use Neosporin on their wounds when they have a little scratch or something like that. But when we're talking about a significant wound, oftentimes the over-the-counter treatments just don't cut it. We need to stimulate that tissue more than just cover it. And, when we start to have a wound that starts getting a sign of a soft yellow scab on it, the thought is most people say, well, that's great, it's going to scab over. But really that biofilm or that early scab is just a little petri dish for bacteria. So we want to remove that and get the tissue underneath it stimulated to grow from the bottom up instead of just covering over in the base of the wound. So our first treatment is just good conservative care, where we treat those wounds with different products and trying to keep them clean and make sure there's no infection. We also use what are called advanced tissue products. And there's a number of different products that we use, and I'll have those on the next slide. And then for the really difficult wounds, we go to what's called hyperbaric oxygen therapy. And that's where we put you in basically in 100% oxygen environment at pressure to try to get more oxygen to the tissue that needs it so that it can heal. The number one question is always, how long is this going to take to heal? And that is a loaded question, and every single patient is different. It depends on the wound, depends on multiple factors that go into healing, as well as your body's ability to heal. And that goes to nutrition, elevation, swelling, lots of different reasons that wounds take different amounts of time to heal. So debridement, which fell under the kind of conservative therapy, is basically to manually clean that wound and remove that exudate or biofilm that your body's putting down to try to heal. We want to keep that clean, keep the bacterial load at an absolute minimum. And then we stimulate the tissue by cleaning it, and it's called sharp debridement, where we actually scrape it and make it bleed, because when we make it bleed, those platelets and other growth factors come to the surface and stimulate the tissue to produce new skin cells or new fat cells, depending on how deep that wound is. And obviously keeping it clean, again, irrigating it afterwards, and then always culturing it at the end when it's as clean as it can possibly be. So if there's any bacteria in the very base of that wound, that's the one we want to treat. We all have bacteria on the surface of our skin at all times. So if we just run a culture over the top, we're going to get a plethora of different types of bacteria that probably aren't involved if there is an infection in that wound. So we want to get a deep, clean wound sample and get that sent for culture to make sure that we're treating the right thing. And this is where the treatment in the wound center differs from a lot of offices, is because we've been doing this a long time and have learned that you really want to get the best sample you can. We use multiple different products on the wounds. Collagen is probably our number one, where we're trying to kind of give your tissue a matrix to grow into and regenerate new skin cells and fill in that wound so it's back to the normal contour of the tissue that's been injured. We use what are called enzymatic debriders, which actually kind of keep the wound clean by breaking down any bacterial load that's there. And silver is one of the other ones that can kind of keep the bacterial load in the wound to a minimum to try to keep it from getting infection. The ointments can vary anywhere from just plain zinc to keep a wound dry that's possibly oozing a lot of clear fluid, and we don't want the skin around it to break down, all the way to a product that's got a lot of silver and collagen mixed in to try to fill that product into the wound and give it a nice clean area to fill. In addition, there's also some kind of clay products that are infused with iodine that keep the wound clean and very dry and allow it to heal up on its own. As we get into more difficult wounds, then we start talking about the advanced tissue products that were mentioned a couple slides ago. We use the collagen sheets, and there's some that are impregnated with a chemical that the bacteria preferentially go to instead of your tissue, and then the bacteria die when they hit that chemical. There are grafts that we get from a company back in Boston that are actual placental membranes. And the reason they use a placental membrane is there's a lot of growth factors in that membrane naturally from, when a child was growing inside of it. And so that tissue, when we lay it onto your wound, those growth factors stimulate the tissue underneath to start building up and trying to regenerate the fatty tissue and the skin cells that we need to get that wound closed. And lastly, there's actual skin that's cultured from human cells that comes directly to us in a Petri dish. And we take that skin and we lay it on the wound instead of having to graft it from another part of your body. It's actually one that comes already grown in the lab, and then we place it on the wound. Interestingly, that doesn't take completely, and so it's usually multiple treatments with a cultured piece of skin to get that wound to start really healing up and get the tissue growing. If we've kind of failed at all of those and the patient meets the right criteria, the next thing we would do is go into what's called hyperbaric oxygen therapy. And everybody's kind of heard of, I think Michael Jackson slept in a hyperbaric chamber, and some other celebrities have tried to do it, try to increase their longevity, but truly it's only indicated for certain kinds of conditions. Diabetic foot wounds that don't heal with other treatments, bone infections, acute hearing loss, that's what we call acute idiopathic hearing loss that happens just overnight. And then several others that normally we would treat in an inpatient setting, so we don't do those in the clinic here. But what hyperbaric oxygen is basically exactly what it sounds. A hyperbaric is we put you into a chamber that's made of plexiglass and is clear, and we increase the pressure slowly until you're approximately 2 atmospheres of pressure, or equivalent to about 60 feet underwater. And then it's 100% oxygen in that environment. So your body only has the ability to carry so much oxygen in your blood, but this increases the partial pressure of that oxygen and allows it to dissipate into your tissues better, to deliver it to tissue that may not be getting enough oxygen and nutrients to heal. When we do that, we also monitor the tissue around the wound with what's called a TCOM, which is a transcutaneous oxygen monitor, to make sure that when you're in room air and then you're in the hyperbaric chamber, that you truly are getting more oxygen to that tissue, to know that we're doing the right thing and get that in there. It also gets that blood, the flow into the bone that could be infected, more oxygen to try to heal that wound and get the bacteria under control. So that's kind of the long and short of what we do on the wound side. Are there any questions on wound care specific questions?
Anyone have any questions? You're welcome to put them in the chat, or you can unmute yourself and speak. I guess one question I'd have is, how do things like, nutrition and fluid intake and all that kind of stuff, how does that all affect?
So hydration for sure is important, because we want your volume in your vascular system to be at its norm and deliver the nutrients and deliver the oxygen to that tissue. And if you're dehydrated, obviously your body is going to kind of preferentially take your blood to your core, to your heart, your lungs, your organs, and not to your periphery, and certainly not to your skin. In that same vein, the nutrition is incredibly important. Keeping your blood sugar, if you're a diabetic, under 180 really increases the chance of healing a wound, because if there's a high blood sugar, the bacteria love blood or love sugar. And so if your blood sugars are really high, it increases your risk for infection. But number two is that you need a lot of protein to heal your wounds and rebuild that tissue. And so having a high protein diet while you're trying to heal a wound is one of the most important things that you can do.
And we have a question from Paula asking where the oxygen, the chamber place, is that at LMH? Is that located there?
No, it's actually at our clinic at 6th and Main.
Okay.
Right. It's about 8 feet away from me right now, because we have to be within, an easy walk to it, because if something were to happen, unfortunately, to a patient, we need to be right here for them. So it's in the office right in the room right next to my office.
Great. Yeah, it almost sounds like magic, you know?
It's pretty neat to watch it happen and watch the wounds really take off after, several weeks. Now, it's not a short process.
Mhm.
Most wounds, it's an 8-week process, 5 days a week for about 90 minutes in the chamber every day of the week, except for the weekends.
So is that considered kind of like the ultimate treatment? I mean, is there anything beyond that you do beyond the oxygen,
Yeah, that's
chamber?
that's really when we get a very difficult wound, that's the combination of conservative wound care, antibiotics, and with infectious disease doctors involved, and then hyperbarics is kind of the gold standard for the difficult wounds.
Okay.
So, Dr. Evans, when someone does have a wound that isn't healing, how long is okay to wait until they reach out? Or what are some of the, I guess, warning signs?
Yeah, and that goes back to what kind of wound it is again, because a lot of post-operative wounds, the surgeons will treat them in their office, and so that might change a little bit. And they usually have kind of a threshold of 4 to 6 weeks, and if it hasn't healed in 4 to 6 weeks, then they send them to us. A lot of the primary care doctors will say, okay, it's been 3 weeks, we're not making any progress here. Let's go ahead and move on to the wound care center and see if they can get this healed.
Thank you.
Any other wound related questions?
Great. Well, we can move
Um,
forward. If
I
you,
have
oh,
one. This
oh,
isn't
sure.
really super serious like the way what you're talking about, but just on a regular cut or something. It's always been the kind of, as it heals, do you leave the Band-Aid on or do you take it off and let it air?
That's a great question. If the wound is moist and starting to get white around the edge, where it looks like you've been in the bathtub for too long and you're getting wrinkly, then yes, you want to let it, kind of air out and dry, at least once or twice a day. But typically what we tell people is, we want these covered so that no other bacteria or contaminants can get in them. And that actually brings up a really good point. One of the other things that you can do with a wound to prevent having to come to me is that when you bathe, to keep that wound covered when you're bathing. Because when you wash off the bacteria from the rest of your body or use a washcloth and it gets into that wound, that increases your risk of infection as well.
And then we also have another question, kind of similar to Maureen's about, covering versus letting it breathe. But then the follow-up is, should one use antibiotic ointment? Is that helpful?
Yes. So yeah, typically the antibiotic ointments for minor wounds are absolutely fine. Again, if that tissue starts to get white and kind of opaque, then it's getting too much moisture and we want it to dry out a little bit.
Okay.
That will keep the scab from actually getting hard if you continue the Neosporin or topical triple antibiotic, but that's okay if it's a minor wound. It's really when it starts to get into a deeper wound where you can see the yellow fatty tissue underneath, then that's something that we probably need to see.
Is there any antibiotic ointment that you recommend over another? I know there's like,
Yeah, almost
Neosporin.
almost all of them are almost exactly the same combination of 3 medications. Most of the triple antibiotics that you can buy over the counter, and quite honestly, the generics are just as good as the brand names, in my opinion. They're usually made in the same factory and just have different labels on them.
Okay. Great.
Okay, let's move on to venous disease. Okay, so veins are another one of my passions because I think a lot of it gets missed. And there is a huge crossover between wound care and vein care. And I'm going to start with that because we get so many venous ulcers on the wound side that typically in centers that don't treat both get missed. That you have a patient who comes in with a wound and it's not recognized that this is actually probably because their veins need to be treated. And so the natural progression is to treat the wound and just keep treating it. And it's not getting better because they're not getting good blood flow to that area to allow it to heal. So sometimes we have to go ahead and treat the vein first to get the wound to heal. So the nice part about this clinic is that we have both. And so there's four different doctors here. And so we kind of bounce back and forth on some patients between taking care of their wound and taking care of their veins to optimize the healing of a venous related wound. So conservative therapy for venous disease is kind of similar as far as what we would do with a wound in a leg that needed to be compressed. And compression is number one. We treat first and foremost with compression stockings, leg wraps, and pneumatic pumps for our conservative therapy for venous disease. And the reason I say we start with that is because every insurance company in the world requires a 3-month trial of conservative therapy for venous disease before they allow any kind of intervention or treatment of those veins. So when people come in the first time, they want to get their veins treated, unless it's a cosmetic procedure, we have to go through a 3-month process of wearing compression stockings while you're awake, exercise and elevation. And then if we need to move on to wraps or pneumatic compression pumps, which literally just start at your toes and slowly inflate and move the fluid in the venous blood back up into your core, that's our starting point. Elevation is very important because venous disease typically is because there's a valve in the vein that has failed. And because we don't have a heart in our legs, we rely on our calf muscle to pump that blood all the way back up to our heart. And if you're sitting in a chair or in a wheelchair or not walking every day, that calf is not working. So that blood just kind of pools in your lower legs. Everybody's been on an airplane or on a long car ride and you notice your shoes start to get tight. That's because you're not using your calves and that fluid is just building up in your tissue. Over time, those valves can fail. And so they don't close properly and allow that blood to actually flow back downhill to your lower leg. And that's when you start to see the kind of chronic changes that we think about venous disease. The loss of hair on the toes and lower legs, discoloration, bulging veins, and there's that little constellation of veins that can happen on the inner ankle. They look like little blue spider veins down there. Those all tell us that there's a venous problem uphill from that. Can be all the way to the groin, where we've got backflow of blood, or reflux is the term that we typically use. The more activity and elevation that you can do, the more venous return you get, which improves not only your symptoms of venous disease, but also the function of your tissue as well. That kind of takes me into what are the symptoms, because a lot of people don't realize that, yeah, there's visible veins that you can have that kind of give you that clue that you've got some venous disease. But the loss of hair, discoloration, swelling, leg cramps, especially at night, inability to walk very far before your legs get really, tired or achy. But if you get pain when you walk, that can be more arterial. Let me move on to our next slide here. So how do we treat these? We talked about the first thing we do is compression, and we do spend 3 months doing compression and follow-ups to make sure that, maybe in a small percentage of our patients, that's all they really need. If they just wear compression stockings, their legs feel great and they don't need to have any intervention done. If they get through that 3-month period and they're still having a lot of their symptoms and they don't feel like when they take the stockings off that their legs feel good, then we start talking about actually doing an intervention, which can be any of these listed on the screen here. The number one thing we do is laser closure of the veins, which is called EVLT, and that stands for endovenous laser therapy. And we actually put a small fiber into the vein and heat up the liquid part of the blood, and it turns into steam. What that steam does is it damages the inside of the vein and causes it to go into spasm, and then it stops working. And so when it stops working, the blood kind of reroutes itself, I describe it as a detour from the highway to a side road, and finds another way to get back to your deep venous system and get returned to your core. Sclerotherapy is a method that we use to close more of the smaller superficial veins, where we actually have a foam that's injected into the vein with a butterfly needle, same needle that they would use to do a blood draw at your local doctor's office or at the hospital. And it has the same kind of mechanism where it causes a little bit of damage to the inside of that vein wall and causes it to shut down. Again, that blood finds a new route through the good veins, and that vein closes. And over the next 3 to 6 months, your body reabsorbs the vein that we closed. If you have really small little spider veins that you don't like the look of, then we do a cosmetic sclerotherapy on those. And it's with a very dilute version of the same medication we use for the sclerotherapy on the bigger veins. And we fill those little spider veins with a needle that's about the size of a hair. So 32 gauge needle, which is almost impossible to see with the naked eye. But we put those in under a magnifying glass and fill those little veins with a sclerosant to make them go away. And the last form of treatment that we do here is called Vein Go. And a lot of people have those little rosy cheeks with spider veins on their cheeks or on their nose. And this is a what we call a micro needle, which is even smaller than the 32 gauge needle. And it has it's attached to an electrical source, and it's a tiny little charge. And when we hit that vein, it closes it down and does the same thing where it shuts the vein down. And typically you don't need more than 1 or 2 treatments to close those down. But that's typically limited to the face and very tender areas where there'd be a lot of pain if we were trying to inject anything. So kind of going back to the compression, because a lot of people have questions about, what kind of compression. Everybody's seen compression stockings. You can have the ones with open toes or closed toed, knee high, or all the way to the thigh. They make them in pantyhose style. They make them in a capri style pants where you can get it up over your waist and thighs, and then it only goes to the mid calf. But in addition to that, there are garments like are pictured on the right there in the top picture, and that's called a cirque. And this is a really great way for people who have bad arthritic problems or mobility problems to be able to put these on, because anybody who's tried to put on a compression stocking will tell you it's like wrestling a bear to get those on, and it's almost as difficult to get them off. So this is a good alternative where you can get about the same amount of compression without having to try to wrestle those stockings onto your legs. And oftentimes we'll refer people who need these over to the lymphedema therapists at the hospital to really get their legs maximized or minimized in size before we size them for the right compression garment. And just below that, you'll see a lady sitting in a pair of, looks like giant pants with feet on them. And that is called a pneumatic compression garment. We use several different companies. And this augments the normal compression that we would use. So you can actually wear those pants over a pair of compression stockings. And it takes about an hour a day. And it starts a slow squeeze at your toes and sequentially comes up all the way to your thighs. They also have attachments for the arms. And somebody was, after a mastectomy and had lymphedema in their arm, you can use it for that as well. When we do refer people to lymphedema therapy, they are physical therapists and occupational therapists that specifically treat lymphedema and venous disease that have a lot of edema. And they do a number of different things. Number one thing is try to get your body to manually remove that fluid from the tissue where it's been pooling. And that can be done with what's called manual lymphatic massage. They will also do serial compression wraps where they'll wrap your leg with a tight material to try to get that fluid out and have you come back several times before they feel like your leg is at the right size to get you into a garment that you'll be able to use at home to manage that venous disease or lymphedema afterwards. The key here is to get the right sized garment. I don't know how many times we have people come in and they're like, I've been wearing compression stockings for 2 years and they don't do anything. And you look at their compression stockings that they bought at Walmart and they're either too tall or too short or too big. So when we size you, we actually measure your ankle size, your calf size, the length of your lower leg. And if you have to have it all the way to the waist, also the circumference of your thigh and the overall length of your leg to make sure that you're getting into the right size that will optimally compress your leg. That's the one thing I think that I would stress to everybody is if you know somebody who's wearing compression stockings, find out if they were actually fitted to them or they just bought them over the counter. Because if they're not working, it's most likely that they're not the right size. So I mentioned lipedema before. So we have lipedema and lymphedema. Lymphedema is just the liquid part of your blood that comes out of the capillary beds that gets stuck in your tissue and is oftentimes just getting that massage and getting moving will help with it, unless you have some sort of obstructive process. And part of our workup for lymphedema is to make sure that there's not a secondary cause for the lymphedema, whether it was a previous surgery, a cancer, a tumor, something compressing the vessel that's not letting that lymphatic tissue come back into your system. On this slide, we talk about lipedema. And lipedema is really interesting because before about 10 years ago, it wasn't even really considered a disease process. And last year, they actually finally gave it a classification where we hope in the near future, the insurance company is going to start covering treatment for this. And we've all seen people and all have people in our family that have this issue. Lipedema is estimated to be 10% of all women in the United States can be diagnosed with lipedema. It is basically an abnormal type of fat that gets deposited in basically the hips and thighs. And it can actually extend down to the feet and in the upper arm, on the back side of the arm. I say abnormal fat because this fat is not the typical fat that is yellow. It's more of a white fat and it is encapsulated. So you get hard nodules in the later stages of the disease that can be extremely painful. You can diet as much as you want and this fat just does not go away. We have people that come in and they've said, I've lost 80 pounds. I've lost it in my stomach. I've lost it in my chest. I've lost it everywhere, but my bottom and my thighs just didn't change at all. And this is lipedema. The kind of hallmarks that we see for it, and you can see the different types and the different stages that are listed on the right-hand side. So different distribution is where we come to what types they are. If it's just the buttocks and thighs, the buttocks, thighs, and calves, or buttocks, thighs, calves, and arms. And then the different stages being a little bit of swelling, starting to get the little nodular look, like in stage 2 there. And the cuffing, which we see at both the knee and the ankle, where you see a little cuff develop. And the last one is where it just turns into hard, nodular, painful areas in the thighs. Treatment for this is actually very similar in the first couple of stages to lymphedema, where we want to use compression. It not only helps bring back some of the fluid that is accumulating there, but it helps with the pain. Manual lymphatic drainage, just like lymphedema, because oftentimes people have a mix of lipedema and lymphedema. And that helps with both the pain and the progression of the disease to try to keep it from getting to that stage 3 or stage 4, where it becomes, life-changing and very painful. And if we get folks that really truly have an immense amount of pain, or it's progressed to that stage 3 or stage 4, we can refer on to very specific plastic surgeons, typically, who specialize in what's called lymphatic sparing liposuction. And the difference there is that they try to avoid the lymphatic vessels, because if you just do liposuction and try to get rid of this abnormal fat, oftentimes you can disrupt the lymphatics and you end up getting the swelling as a result of it. So the closest person that we have is in St. Louis, and we send probably 2 or 3 people a year to him to get evaluated and see if they'd be a candidate for surgery. Nope, I think we lost a slide. Okay. Nope. There was a lymphedema slide too, but we covered lymphedema pretty carefully there. I think the biggest thing on the lymphedema is to know that we work in conjunction with the lymphedema therapist in the occupational therapy clinic. And there's one at the hospital and there's one here at 6th and Main. So it all depends on convenience where you want to be seen. Okay. Any questions on the venous side here? I always tend to get a lot of these.
Yeah, there's quite a few actually. Relative to failed valves, can they be replaced or otherwise improved?
In extreme cases, and usually only in the deep venous system, there can be a vascular procedure where they remove a vein from somewhere else that has a competent valve and replace it in there. I have not seen a patient that's ever had that done. That's how rare it is. It
Wow.
usually has to do with a major crush injury where the vein is, a large section of the vein is damaged in the deep venous system.
So how do you diagnose or locate the damaged area of the vein?
Great question. Great question. Yeah. So what we do is called a mapping ultrasound here. And everybody's seen an ultrasound, probably had an ultrasound at some point in their life. We do this ultrasound standing. It takes about an hour. And we literally draw a map of your veins while we're doing the ultrasound. And what we're looking for is that backwards flow. When we see blood moving up the vein, and then when it comes back down for more than half a second, we know that there's a valve at that location or above that location that has failed. So our ultrasonographer spends about an hour on all the veins that we would typically treat and finds the ones that aren't functioning right, gives us a size and how much they're backflowing or refluxing to determine where the treatment needs to occur on that leg.
And this is a comment on, as a breast cancer patient, she had lymphedema in her left hand and needed physical therapy treatment before controlling it herself.
Mhm.
Is that fairly common?
Yes, in fact, yeah, oftentimes with breast cancer, if they do lymph node biopsies or take out lymph nodes in the armpit, lymphedema is a very common secondary problem there. And it's sometimes after radiation therapy for breast cancer as well.
And will insurance pay for compression hose for the fitting for the patient?
For the fitting,
Yeah.
yeah, so we do that on the first visit with most people. And the fitting itself is part of our evaluation. The actual cost of the compression stockings, I don't know of any other than the VA who pay for compression stockings, but the fitting is actually part of that process. The other place you can get fitted are several of the pharmacies here in town if you don't want to be seen. Medical Arts and Sigler both will measure the same way that we do to ensure that you get the right size.
Okay. So I guess getting back to the question between the over-the-counter versus the prescription ones, the difference is the fit then, or are they comparable in quality?
Not necessarily. So
Okay.
some of them are. There are different strengths of compression. A lot of the over-the-counter ones are what we call 15 to 20, and that's 15 to 20 milligrams of mercury compression. For you to get approved for any kind of treatment, you have to be in 20 to 30 millimeters of mercury compression or higher. So if you just buy the basic ones at Walmart over the counter, if it's not a 20, 30, it's not adequate to get through the conservative therapy portion of your treatment to get qualified for insurance coverage.
Okay. And then another question about lipedema, is it often genetic?
Absolutely. It's almost, there's a huge genetic component in it. And oftentimes, and I skipped over this before, but that's a really good question. It's mainly with big hormonal changes in women. So the first time that fat starts getting deposited is with the first period, early in the early teens. And the girls will start put on a little hip and buttocks fat. And then with each pregnancy and with menopause, each one of those causes it to get worse. And the genetic component there is oftentimes, yes, my aunt and my grandmother both looked like this, but it skipped my mom. So it's definitely genetic.
Okay. And is it known what causes lipedema?
No, that's hopefully we will get to that eventually.
Yeah. And then a question, do all varicose veins need to be treated?
Absolutely not. Yeah. I mean, there's a lot of people who just have very prominent veins, and those veins can be large enough to treat, but not be symptomatic. So in order to be treated, you have to have certain criteria met. The vein has to be a certain size, and you have to have a number of different symptoms, which can be aching, heaviness, swelling, cramping, spontaneous bruising or bleeding, or skin changes or ulceration. So if you come in and you've got huge varicose veins, but you walk 6 miles a day, and you don't have any limitations to what you do on a daily basis, and you don't get night cramps or have any chronic skin changes, your insurance company is not going to pay for treatment on those veins. So those people are usually ones that just get compression if they want it, but if they're asymptomatic, they really don't have to do anything.
All right. And then this is an interesting question that actually has a little bit more to do on the wound side of things.
Okay.
Relative to minor wounds, do you recommend treatment such as super glue to close the wound?
In the right environment, yes. I think if you have a minor wound in the emergency department that is not all the way through the skin into the fatty layer, that super glue or Dermabond is the medical grade super glue is an excellent way to treat those because it makes a nice seal. It keeps the bacteria out of the wound, and typically they have really great cosmetic outcomes.
So can you use just any super glue, or there's medical super glue? I
No,
guess.
there's certain ones, and for little scratches and stuff, there's that liquid Band-Aid you can buy over the counter.
right.
It's a similar one, but it's not sterile like the one that we would use in the hospital or in the office setting.
Let's see. Shelley, did you have a question about leg cramps?
Yeah, I was wondering if they were always indicative of the beginnings of this, or is that just a general symptom of many other things as well?
Yeah, there's a lot of causes of leg cramps. The big thing that we talk about is that if your legs start to cramp at night, and we have to make a distinction here because there's also restless legs, where typically people at night just have to move all the time because their legs hurt. Typically, it's not pain, it's more muscle cramping, because part of venous disease is that since you're not returning that venous blood, it's already used all the oxygen in that blood into your tissue, into your muscles, and your muscles want more oxygen. And so you start to get cramps. And people will tell me, and this is a really kind of good way to screen yourself, is that if you have to get up and walk around for that cramp to go away, you might be screaming for oxygen in the middle of the night in your legs and that muscle, and that can be an indicator of this could be a venous problem. If you just have muscle cramps all the time or intermittently, that's probably not specifically a venous problem. You can also have electrolyte abnormalities. You can have, arterial flow abnormalities that are causing pain. And those typically, you'll get pain when you walk, where venous insufficiency gets better when you walk. So that's one of our other distinctions, is if you have pain in your legs and you get up and walk and it gets better, that's probably venous. If you walk and you get pain, that's probably arterial.
Okay. Anybody else have any questions? Either on the wound side or the vein side of the presentation. All right. Great. Well, you know what? I was going to unshare your screen if that's okay.
That's
Are you
fine.
okay? I want to. Yes. See. Nope. It's not working.
Here, I can unshare it on mine.
Yeah. I don't know why it's not cooperating. There we go. Just wanted to pop back into the Brady Bunch theme here with our Hollywood Squares look. So before we go, you got one last opportunity to ask some questions. Yes, Gary, you can unmute yourself.
Okay, back on the slide where you were showing the compression stockings or the compression.
Yes.
That one on the right, that top one, what did you call that?
It's called a Circaid, CIRCAID. And there are several different companies that make those with different names. That's just the brand name of that one. You could refer to it just as a Velcro compression stocking as well.
Okay, is that like a wrap?
It is. It's multiple wraps that are all connected in the back. So you start by attaching the bottom one around your ankle first, and just go sequentially, and they kind of overlap each other. So there's no pooching of the skin between the different layers.
So that you would have to kind of tighten to whatever amount that you think you need.
Yeah, and it's pretty when they size them for you, it will pretty much give you the compression that they want from the occupational therapist perspective to give you that 20-30 compression. That's the way that they're made.
And Sigler, you said that they do the measurements. Are they, do you have to have a prescription to get that, or is that you can just go into their pharmacy and?
You need to have a prescription for them, and you can get that either from us or from a primary care provider. And on the 20-30s, actually, you may not, I may have misspoken. The 20-30s, you may not have to have a prescription for those. They may have them that you can buy over the counter and they can size you for them. I'm not sure if they do the sizing for the circades. It's pretty rare that the pharmacies actually carry the Velcro wraps.
Okay. Thank you.
We've got another question from Maggie and Dave. Is putting your toes towards your nose for leg cramp relief the same as walking?
No, that actually is stretching out the muscle that's cramping up when you're trying to kind of, we call, dorsiflex the foot or put it up against the wall and stretch it out. That really does help with that muscle cramp. But when we're talking about venous disease and walking, we're using that calf muscle to push the blood out of there and deliver fresh blood to the tissue that then alleviates the cramp. Because the cramp in the venous disease is actually coming because of the lack of oxygen in the tissue.
All right. And then, Paula, did you have a question about genetics? Oh, you want to unmute?
Yes, it might be kind of noisy here. Yes, I just wondering how often is this a genetic condition? Does it run in your mother, your grandma, and then me, my sisters? Is that common or not?
Very common. I'd say 50% of venous disease is probably genetic, and then environmental. Teachers, people who work in factories, walking on hard concrete. We see trends in that. Teachers who are on their feet 8 hours a day, people who work at Hallmark, working on a hard surface where they're always on their feet. There's a huge component there. A lot of our patients, it's genetic and solely genetic, where there's not a lot of external temper. The other thing is injuries. If you've had, hip surgery, knee surgery, got hit by a car, took a softball to the thigh, all of those things can cause a venous injury that can cause a valve to become incompetent. And over time, you start to get venous reflux and congestion.
Another question, you mentioned raising your legs. Do you suggest or recommend sleeping with your legs elevated at night?
For venous disease and lymphedema, no, because really it's the return mechanism that you need. Once you're horizontal, you're not having to fight gravity to get that blood returned. If your legs are at the same level of your heart, then you shouldn't have any issue with the circulatory return of the venous blood. They may make them feel better.
And then Shelley has asked, is fidgeting helpful when sitting is required to keep the blood moving?
So I always tell people to do toe raises, or if you're just sitting in your chair and you raise up your knees up with your toe, with just toe touch, especially if you're traveling long distances in the car, sitting at a meeting like this, on an airplane, just doing that will keep that blood pumping by activating that calf muscle, which is the pump, which is pushing that blood back up into your core. That was a great question.
Checking to see if anybody has any additional questions. You can raise your hand or unmute if you feel like asking. We're getting a little close to 5 o'clock. But yeah, this has been really informative. David, did you have a question? I'm sorry.
Yeah, if you have never had compression socks and you want to get started on something like that, where do you start? Do you start at the Walmarts or
No.
the drugstore?
Yeah, I would start with a drugstore that can measure you properly, or you can come in to see us if you have swelling that you want to try to get compressed. Your primary care doctor, typically, they can also prescribe them. Hopefully, they'll have a specific prescription pad telling you what they want. Most offices do have those because the question is, do you want an open toe or a closed toe? And people with wide feet typically want an open toe so they can wear a sock over it because it really compresses your toes if you have a wide foot. Also, is it knee high or thigh high? Depending on how far your edema is, how far up it goes on your leg. It depends on which size and height of the stocking that you need.
Okay.
So do you have recommendations in terms of like prevention to keep your veins healthy and
Keep active. I mean, truly, sedentary lifestyle is the kicker for veins. I mean, if you're sitting and not getting up every hour and walking around and moving, that's when we start to see venous pooling. We start to see the chronic venous congestion in the feet and lower legs. You get changes that a lot of times can be prevented with activity. One of the big things about venous disease is if you don't get it early and do regular maintenance, that's when we get wounds that then take a tremendous amount of time to heal. So I always kind of tell people the first time they're here, this is your tune-up, and then we're going to do an annual check on your legs and make sure that we're staying ahead of this so that we don't get to the point where you're going to end up with tissue that's angry, thickened, and has a wound that won't heal.
Another question from the Smiths, if you have neuropathy, can you wear compression socks?
You can, but you have to monitor on a daily basis, especially if you've got any kind of foot deformity. We want to make sure that we are wearing something that's not going to cause extra pressure on an area that's already at risk for compromise.
All right. Wow, that was a lot of great information. A lot of thank yous coming in through the chat, and we really, really appreciate it. Thank you.
Absolutely. I'm glad to do it.
Yeah. And I wanted to just put a plug in for our next Gray Anatomy session is coming up on February 21st, and the topic is memory and fine motor skills with the LMH neurology department. And I will say that kind of kicks off a series with the library as well. In March and April, we'll have 2 sessions on Alzheimer's and dementia, one on March 8th and one on April 4th. So those 3 together, I think, will work really, really well and be super informative. So we have a new reader magazine coming out here in a couple of weeks, so be sure to check that out and mark your calendars for these upcoming sessions. So thank you again. My goodness, Dr. Evans, you were awesome. And Allison, thank you for all your great work and partnerships. These are so helpful and really our most popular programs that we offer as part of the Retirement Bootcamp series.
Well, thank you for having me. I enjoyed it.
All righty. Everybody have a great night, and we'll see you back here on February 21st, if not before. All right, take care.